Welcome to the Explainer. Today, we're putting together a highly structured, comprehensive guide tailored specifically for you, hospital staff, doctors, APPs, and nurses. Look, when a patient needs a painful procedure outside of the OR, we've got to provide comfort without compromising their airway. It's essentially a high-wire act of pharmacology, intense monitoring, and super strict protocols. So let's just get right into how we keep our patients perfectly stable and completely safe. Okay, let's quickly look at our roadmap for today. We'll be covering 1, the sedation continuum, 2, privileges and authorized personnel, 3, the pre-sedation patient assessment, 4, selecting the right medications, and finally, 5, monitoring and patient safety. Starting right off with Section 1, the sedation continuum. The biggest takeaway here is that sedation is not some fixed, static state, but a highly fluid journey. Now, visually mapping out this fluid journey reveals a whole lot. Look at how these states literally stack right on top of one another, from minimal sedation going all the way up to general anesthesia. As our sources point out, it's incredibly common for a patient to inadvertently drift through multiple levels of sedation during a single clinical event. You might be aiming for moderate sedation, but suddenly, whoops, your patient slips into deep sedation or even general anesthesia. Understanding that this drift is a totally normal, expected risk, that's exactly what keeps you hypervigilant. The American Society of Anesthesiologists draws some really strict clinical parameters here. Notice the stark differences as you move deeper. So under moderate or conscious sedation, spontaneous ventilation is totally adequate, and the patient doesn't need any airway intervention. But cross that invisible line into deep sedation, suddenly protective reflexes vanish, and airway intervention might absolutely be required. And, well, this brings us to the non-negotiable rescue principle. Because patients naturally drift down that continuum we just talked about, the clinical mandate is absolute. If you intend to induce moderate sedation, you have to be fully equipped and skilled to rescue them from deep sedation or general anesthesia. Simply put, if you can't confidently manage a crashed airway with a bag valve mask, you really have no business pushing these drugs. Moving right along to Section 2, privileges and authorized personnel, focusing on who can actually do this. Okay, this quote from our sources might sound a little blunt, but it is literally the golden rule of procedural sedation. Regardless of how extensive your training is, the absolute rule is that facility-specific credentialing in your hospital's policy dictate your actions. If your hospital doesn't have a clear policy granting you the privileges to administer these sedatives, don't do it. You absolutely must stay strictly within your scope of practice and your facility's authorized protocols. No exceptions. Let's look at how we build out our clinical safety net by strictly separating bedside roles. You just can't safely fix a dislocated shoulder and manage a patient's airway at the exact same time, right? The credentialed procedural physician is dedicated solely to performing the procedure itself, and right alongside them must be a dedicated registered nurse. This RN's entire job is to provide continuous one-on-one monitoring of the patient's vitals and airway. They should have zero other patient assignments pulling their attention away, period. All right, on to Section 3, pre-sedation patient assessment, because poor patient selection is a massive driver of adverse events. When we're screening these patients, we rely heavily on the ASA Physical Status Classification System. Now, ASA classes 1 and 2, basically your generally healthy patients, or folks with mild controlled systemic disease, those are for sure your safest bets. However, if you've got an ASA level 3 patient with severe systemic disease, or maybe someone with a high Matlin-Potty score that points to a difficult airway, that demands a really serious reevaluation of your game plan. You might even need an anesthesia consult, or the whole procedure might just need to be moved to the OR entirely. Oh, and please don't forget the required documentation. Before proceeding, you've got to ensure that a thorough physical examination and patient history are fully documented. And here's the kicker. For this paperwork to be valid for procedural sedation, it has to be up to date within the last 6 months. 6 months! Things change so rapidly in a patient's health profile, so relying on old medical history is just a massive liability. Now for the fun stuff, pharmacology. Section 4, selecting the right medications. So there's obviously no one-size-fits-all drug here. Navigating these pharmacological choices can definitely feel daunting, but honestly, it boils down to 2 key factors: the patient's baseline cardiopulmonary health and exactly how long you anticipate the procedure is going to take. I mean, are we talking about a quick 5-minute joint reduction or a really complex 20-minute orthopedic repair? Let's compare our heavy hitters. Ketamine is a dissociative that wonderfully maintains airway reflexes, which makes it incredibly safe for longer procedures, especially in kids. Propofol, on the other hand, gives you this rapid, beautiful muscle relaxation, but, and this is a huge but, it carries a very real risk of sudden apnea. Propofol is incredibly fast at putting a patient out, but it's also incredibly fast at making your patient stop breathing entirely. So your airway skills, they have to be razor sharp. Now here's a really interesting nuance you definitely need to be aware of. Etomidate. Etomidate is brilliant for a quick, shocking procedure, like a cardioversion, because it's highly cardioprotective. It's not going to tank your patient's blood pressure. But you have to remember that it is purely a sedative. It'll knock the patient out, sure, but it provides literally zero analgesic pain relief. None. So if you're doing a painful procedure, using etomidate alone will leave the patient suffering, even if they look like they're fast asleep. You absolutely have to manage their pain separately. Finally, we've reached Section 5. Monitoring and patient safety. This is where the rubber meets the road. Preparation is absolutely everything here. Before you push a single milligram of sedative, this 4-step setup is completely non-negotiable. 1. Active suction, ready and turned on. 2. Your bag valve mask, connected to oxygen. 3. Your intubation equipment. And 4. Reversal agents like naloxone, drawn and sitting right at the bedside. You simply cannot afford to be scrambling through random drawers looking for a bag after your patient has already turned blue. And when it comes to monitoring, this next point is a non-negotiable standard of care. You must utilize end-tidal CO2 monitoring, also known as capnography. If you're relying solely on a pulse oximeter to tell you if your patient is breathing, you are going to recognize their apnea way too late. Oxygen saturation can stay artificially high for minutes after a patient actually stops breathing, especially if they're on supplemental oxygen. Capnography gives you second-by-second data, detecting hypoventilation long before that oxygen drops, which gives you the time to intervene immediately. We've covered the critical clinical skills, the pharmacology, and the safety nets required to safely navigate the sedation continuum. But before you start your very next shift, you really have to ask yourself, do you actually know your facility's exact policy for who can push these drugs? Never just assume. Verify your credentials, prepare meticulously for every single procedure, and always respect the profound, kind of terrifying privilege of taking a patient's airway into your own hands. Thanks so much for joining me on this explainer. Stay safe out there.